Started your time.
Shall I start, ma'am?
Yeah, you start.
Hello, I'm Yogini, one of the exam candidates. I have read the scenario and I'm ready for the discussion.
No, you take your 2 minutes time. I started your 2 minutes time. I have started again your 2 minutes time. So take your 2 minute time.
Okay.
Start.
Hello, I'm Yogini. I'm one of the exam candidate and I have read the scenario and I'm ready for the discussion.
Okay. So, Dr. Yogini, can you just tell me how you are now going to see this patient in the antenatal clinic? So, how you are going to manage her antenatally?
Here is a patient who is into her second pregnancy and she is 7 weeks pregnant right now. And I can see that her partner is also a sickle cell carrier. So, as she is into her early pregnancy, I would like to gather some information regarding her sickle cell disease as well as the pregnancy status. So, in the history, I would like to ask her when she had been diagnosed with the sickle cell disease and how she is doing so far, and when was her last visit to her specialist doctor. And this pregnancy is planned pregnancy or it is a spontaneous with unplanned pregnancy, I would like to know. And I would like to gather information regarding her medications, whether she is on hydroxyurea or vaccination, which she is on, and any vaccine is due, I would be noting on that. If she has taken antibiotic and continuing the penicillin prophylaxis, that has to be noted. And I would like to see whether she has done her checkup. Many checkups are due. Like I would like to know about her eye checkup, renal checkup, and also the echo to rule out any complication she has. Then I would like to gather information regarding her symptoms, whether she has any symptoms for sickle cell disease like the breathlessness or shortness of breath, tiredness to rule out anemia or any acute chest syndrome, and her cycles, how they are, whether there is any heavy bleeding, and also any urinary tract infection symptom she has to rule out urinary tract infection. And after that, I would like to know whether she has done antenatal checkups or this is the first visit to the hospital. If it is, then I would like to send her basic antenatal investigation, and I would like to do a viable scan as well. So this will be my first antenatal investigation as well as history I would like to do for this patient.
Okay. Anything else you wanted to say? Can I go to the next page? Next question? Can I go to the next question?
Yeah.
Okay. So now, regarding her and please unmute yourself, whoever is having this. Yeah. Whoever is having this disturbances, please unmute yourself. Okay. Now coming to the next question. This patient at 32 weeks of gestation presented to the emergency with complaints of right hip joint pain. So how you are going to manage her further?
So because she is at 32 weeks with right hip pain, I would be having a suspicion about acute hip necrosis, the head of the femur. So this is an emergency situation. I would like to admit the patient and start with analgesics. Because she is 32, we cannot give her NSAIDs. So I will be offering her with paracetamol or codeine. If it is not relieved, then we may have to consider for morphine. And oxygen will be provided to her to maintain the oxygen saturation above 94, and proper hydration is also necessary. So we can start with IV fluids, maintaining the fluid level at around 60 ml per minute, because this patient may be a candidate for preeclampsia as well. We need to monitor the fluid input as well. So, and I would like to involve my multidisciplinary team, including myself, my consultant, and a hematologist, to take input from transfusion if it is required, because it's an emergency. She may require blood transfusion as well. And I will send the basic investigation like full blood count, RFT, LFT, red cell antibodies if it is not done, and also reticulocyte count. Screening for overload also will be done, and I may have to consider for antibiotic if I am suspecting any infection. Blood and blood pressure, urine monitoring will be done on the Meos chart, and this patient needs admission at the high dependency unit. If it is severe, maybe a critical care unit also has to be done. So monitoring will be done for this patient, and we need to prevent her hypoxia and also acidosis. So I will keep in mind all these things, and patient needs further evaluation as well. Tackle this.
Okay, now this episode has eventually taken care by the MDT. She has responded well to the conservative line of management and she went home. At around 39 weeks of gestation, again she presented at 9 o'clock in the evening, 9 o'clock in the night with labor pain. So, how will you going to manage her now onward?
Yeah, this patient, because she is in labor and 39 weeks, so she needs admission to the labor theater, labor ward, and continuous monitoring will be done with continuous CTG monitoring. Meostat will be put, which includes pulse rate, blood pressure, urine output, input output, as well as oxygen saturation. And patient needs to be in a quiet place, because overexertion, stress, dehydration uh, will cause a sickle crisis. I will keep in mind all these factors, and I will start with pain relief medication. Probably because she is in labor, I would take help of anesthetist, and also my consultant will be involved in her care. One-to-one care will be given by the labor ward midwife, who will be expertise to handle sickle cell disease, and hematologist input is mandatory. We may have to do a blood cross match and keep ready blood. She may require blood transfusion as well after the delivery. So patient requires continuous CTG monitoring and a partogram. If factors are responsible, if she is in a labor and there is no contraindication for normal delivery, we can allow her for normal delivery. In case any delay is there, that is the prolonged stage of labor happens more than 12 hours, patient may be considered for cesarean section because these patients are more prone for crisis in the labor. So I will be monitoring and further monitoring with the help of labor team. So if she delivers, that patient will be taken care of the team.
Okay. So now, in the middle of the night, the patient delivered vaginally. What will be her post-delivery care plan?
So immediately after delivery, she is more prone for dehydration, stress of labor. So she'll be more prone for crisis, sickle cell crisis, as well as pulmonary embolism. So and postpartum hemorrhage is also common in this patient. So I will keep a vigilant on all these factors. Her pulse rate, blood pressure, all vital signs will be monitored, and the input output also put on the chart, news chart. And so to prevent dehydration, I will be starting IV fluids that will be continued. Oxytocin will be continued to prevent postpartum hemorrhage. For she is more prone for thrombosis as well, venous thrombosis. So I will be considering for early mobilization stockings to prevent thromboprophylaxis. If she delivers normally, the thromboprophylaxis will be continued for 7 days. And if it is cesarean section, it will be continued for 6 weeks. So adequate pain relief is also mandatory in such women because we may have to consider higher analgesics if she is not responding for the normal analgesic what we have started in the labor process. So the highest one will be the morphine, but I need monitoring for the patient's respiratory system. So immediately after delivery, the baby will be handed over to the pediatrician to check for the baby status because this patient is sickle cell and the partner is sickle cell trait. So there is chance that the baby may have sickling in 50% or carrier status in 50% of the babies. So the heel prick test will be done on day 5, that will be taken over by the patient. If we have started with morphine, baby may have hypoxic feature, that is withdrawal symptoms. So the pediatrician will be monitoring the patient, and the one-to-one care will be given to the patient. She can breastfeed the baby, and reliable contraceptive methods will be discussed with the patient before she gets discharged. So the most commonly used are all the contraceptive method except for combined contraceptive pill should be avoided. So we will be discussing about all this in the postnatal period, and we need to prevent urinary tract infections or any other infections which can trigger sickling crisis.
Okay, thank you. Anything else you wanted to add? We have already running out of time. Last, you have completed your 10 minutes time.
Thank you for your time.
Okay. Okay. And now your own feedback regarding this task. Then we will ask others also to comment about your answer key, and then we will go ahead with the feedback and answer key.
I don't know, ma'am. Ma'am, actually, I knew this case, so I was prepared.
Okay, so what do you think about your own performance? Are you satisfied? Are you happy? Or do you think, no, I'm not happy with my presentation, I need to improve on certain points? Whatever, everybody knew everyone. Everyone knew the task, everyone knew the stations. But still, in spite of all those things, also, you do have some problem. Okay, you may you may have difficulty in those communication, using the right words at right time. So there are multiple things. So your own reflection, what you want to say about your task?
Maybe I have achieved 50%. Rest all I don't know. You have to give me feedback.
Okay. Now coming to others, uh, would you like to comment on her performance? There are many plenty. Okay, so 13 students today. So anybody would like to comment on who is your study buddy?
I have right
Hello?
now. I'm searching.
Ma'am, can I add?
Hello, ma'am.
Yes, yes, Rajni.
Uh, so, ma'am, like her first question was she has come for a like at the 7 weeks she has come and she's means the question was like how would you take her antenatal care, right? Was that
Hmm.
Uh,
Yes.
uh, so, ma'am, in that I can also tell her means ask her a reference for genetic counselor that in case if it is affected, then further test can be done and ask her to keep taking her antibiotics. And vaccinations she did tell, and aspirin if that has been started or not, and the higher dose of folic acid, and also the frequent scans will be done starting from 24 weeks. So that, and the red flag signs has to be told to her that any time if she feels that means there is burning micturition or sputum, cough, fever, then she should report to us immediately because those would be a trigger factor for the infections. And other means these are the points which comes to my mind. And then the second question was she came at with pain in the hip at around, she came around 37 weeks, that is what, or 36 weeks you told. So in that she told about the admission and the fluids, with restriction of fluids, oxygen, and keeping herself warm, and the step ladder pattern of analgesics did she did tell. And to add on, we can tell that we have to means within 1 hour pain should be relieved, and along with that, if it is not, we can also give her parental opioids if required. And secondly, we have to monitor her this her pain score, respiratory, and the sedation score, which has to be monitored to at the beginning of 20 to 30 minutes, and then it can be 2 hourly or 1 hourly depending on if she is on parental opioids or oral opioids. And HDU admission has to be that. Along with that, we also have to add antiemetics because the opioids might be precipitating her vomiting, and we can add some laxatives and antihistaminics as well. And we can consider reducing the dose of the analgesics over a period of 2 to 3 days, and that we have to tell her. And then since she had a hospital admission, so we can also add this blood thinning agents as well. So these are just the points to add on. And then when she came at the time of delivery, at the time of delivery, uh, um, she mostly the means the pain relief option has to be told to her. I think this she told properly. And also I have to make sure of the position of the baby, of the mother, because if means if there is a but the position has to be means other options can be given to deliver, because she had a pain of avascular necrosis in the beginning, so that has to be kept into consideration. And other points she told. And after the uh, and ma'am, I think the other points she did tell.
Okay. Good observation. Very good observation. Uh, Very good observation. Anybody else wanted to say anything? No. Okay. So sorry. Uh, okay. So Yogini, I didn't hear. Who is your study buddy? Hello.
Ma'am, I had previously. Now I don't have. So
You are appearing for exam? Me?
yes, ma'am. Yes.
Without study buddy?
Yeah.
No, dear. Not to discourage you, but see to it that if you can find it out or you can club it with people who are already having it. Okay,
Okay,
it is
ma'am.
very important. Yeah, it is very important to have someone to reflect on yourself. Okay, because we are always biased. Anybody wants to say anything?
Yes, ma'am. I want to tell, ma'am.
Huh?
Uh, when I was preparing for third part, I was presenting on my own. Prajakta ma'am only advised me to do only if you do with study partner, I will give you feedback. I was not able to record, so I stopped presenting cases and started doing with study partners. That only helped me to pass. So she is the one who has given the apt advice for me so that it helped me to pass the exam. Thank you, ma'am.
Yeah, thank you, dear, for appreciating me. It is not just to take a appreciation from somebody else. This is actually a need. We need to reflect on our own mistakes. Unless and until we will not reflect on our own mistakes, we may keep on doing the same mistakes. And that's the reason that study buddy with whom you can match up your frequency is very important. And that's the reason we are suggesting for these courses also. It is not for spending so much of money, it is just to keep you on a right track on right time, not to get deviated. Okay, that is my concern. It's up to you, dear, not to discourage you at this point. Whatever you are doing, do yourself. But if at all you can think of clubbing up with some group or somebody who is already studying, just see whether it is possible. Okay, let them present 2 or 3 tasks, and you can present 1 or 2 tasks. Now, coming, not to dishearten you, you have done a good job, but why you have stopped at 7 weeks, dear? Antenatal care management, it stops at delivery. Okay, it stops at delivery. You just stopped at 7 weeks. Why? I don't understand that. Okay, so in the beginning, the best part about this presentation, Dr. Yogini, you had presented it as a structured discussion. Once or twice only you use lay language, but still I will say that it is pardonable, because many a time students do keep on mixing the SPT language, means the language of lay language, and uh, they will not use the medical terminology or medical jargons. So in that case, I will definitely give you full on, because you interacted with the colleague in a very structured medical language. Okay, so that colleague environment, communication with colleague was very good. That is a clear pass for you in this domain. Regarding information gathering also, although information gathering has not been tested in this domain. Okay, so three only domains are being tested: patient safety, communication with colleague, and applied clinical knowledge. So information gathering is not tested, but then information gathering is needed because we need to pass patient safety domain. Okay, acknowledging the information whichever has been given to us and interpretation of the information, along with few basic information we need to know. So the basic S bar, if you can imply S bar when you starting your answer key, will be very high, very good. I had started with the situation that a high risk pregnancy due to sickle cell anemia or sickle cell disease. Okay, in a second gravida with early gestation. That is my background here. But my situation here is sickle cell anemia disease case with early pregnancy. So this is my high risk pregnancy. Okay, I'm not any, somewhere you have to mention that she is a high risk pregnancy. The way you had mentioned about MDT, but somewhere you have to mention, okay, she is a high risk pregnancy. So my, yes, dear. Anybody wanted to say anything? Shall I continue? Am I audible?
Yes, ma'am.
Thank you. So now go systematically. So here you started with her sickle cell, then you asked her about planned pregnancy, unplanned pregnancy. So as we are doing in SPT, as we are doing in stimulated patient task, we need to here also involve open question first and then go into the closed question. So something like that. I wanted to know about her current pregnancy. So I had started from current pregnancy. No harm whether you wanted to take illicit medicine history, medical history, or pregnancy history, any history, but you just say, thou, I wanted to elicit history regarding her current pregnancy. Rightly said, planned, unplanned, which contraception she was using, whether she took pre-pregnancy clinic advised in this pregnancy. Okay, so that is very important because then that suggests that she has been optimized her and her health has been optimized or not. So previous pregnancy details also I would like to know whether it has resulted into live birth, missed means any abortion outcome. Okay, that also I wanted to know. Okay, since how long and all those things, dear, sickle cell disease doesn't means carry here anything. In the relevant sickle cell disease history will be something. Uh, when was her last admission? When was her last follow-up? On what medication she is on whether she has completed her vaccination, penicillin prophylaxis is there, and organ function. Okay, because these patients are at risk of uh, this pulmonary hypertension, kidney failure, renal failure due to iron overload, retinal changes. Okay, yeah. So we need to rule out this by offering this when she has assessed for all these things. Yearly 2D echo, pulmonary function test also I had mentioned, but they do not offer pulmonary function test, liver function test, kidney function test, red cell antibodies. Okay, when was her last admission and last transfusion, iron overload assessment, that is serum ferritin, retinal screening when it was done, and last follow up and last hemoglobin, because whether she is having any anemia or not. Treatment and vaccination status, flu medicine, penicillin prophylaxis, other risk factor. Okay, something like that. Support, even you can ask in this treatment history, folic acid, high dose folic acid, whether she is on that. Continue high dose folic acid till delivery, he will be continuing, that also you need to say. Support at home, distance from home for access of care in case of emergency, and other history which is significant in her case, medical, surgical, allergy, smoking and occupation, max to max, and BMI. These are my history. Okay, blood group. Root red cell antibodies, blood group. So smoking, alcohol, occupation, BMI, blood group. So this is only my relevant history which I would like to gather. After that, I wanted to check her concerns, whether she's having any specific concerns. Here I will take an opportunity to explain her regarding the implication of sickle cell disease on her pregnancy and pregnancy on sickle cell disease. So sickle cell disease will increases the risk of preeclampsia, thromboembolic events, SGA, IUGR, stillbirth, induction of labor, need of induction of labor, preterm labor, C-section, BB being carrier or affected. Okay, both. Not only carrier, but here it will be affected also. Okay, since it is autosomal disease, autosomal dominant disorder. Okay, in now this
Ma'am,
pregnancy, how? Yes, dear.
it's recessive, right?
Yeah, sorry. Yes, it is in my. Okay, yes, my mistake. It was into the under the flow of thoughts. Okay, so it is AR. Okay, so how this pregnancy is going to affect SCD? There are more chances of having a painful crisis, acute chest syndrome, anemia, blood transfusion, frequent admission, urinary tract infection, and nausea, vomiting of pregnancy may aggravate crisis. Okay, bone crisis, pain crisis or bone crisis is the same because of this thromboembolic effect. And another thing is acute chest syndrome. Okay, at risk of infections. So these are the implications. You have to tell her, Anjana, I had acknowledged you, you had admitted. Okay, so don't worry. After this, your task is there. Yeah.
Okay, ma'am.
Now, yeah. So to minimize, now after explaining the high risk nature of her pregnancy, to minimize the consequences and complications associated with this pregnancy, the MDT management will be offered to this patient. So it will include consultant-led care unit, hematologist, nurse specialist, midwife, GP with interest in sickle cell disease. Here again, fetal medicine experts and genetic counselor will be involved in her care, because this baby is at risk of having affection or a carrier, affected sickle cell disease or carrier. So urgent review from sickle cell disease team and assess her organ function, which is very important here. And treatment modalities. If she is on hydroxylurea, that needs to be stopped, and any other medication can be added to this patient. Continue medication, continue vaccination, folic acid. Okay, here high dose folic acid needs to be continued. I had mentioned somewhere. Okay, here I had not mentioned. So folic acid, which will be high dose, and it needs to be continued till delivery. Why? It is not for the prevention of neural NTD. It is for that anemia prevention. Okay, so that is for that is. Then offer antenatal care, early ultrasonography to rule out fetal viability. Very important. At 7 weeks, we just need to rule out fetal viability. Okay, and genetic reference for assessment, and fetal medicine experts involvement for CVS or NIPT. NIPT will allow us to know this baby is having SCD, sickle cell disease. Anybody can comment?
Yes, I guess. I'm not sure.
Yes, yeah, even I guess, but we can confirm. So, non-invasive or invasive way of modalities will be offered for the baby's detection. Okay, baby's fetal RBCs are present in the maternal blood. So, from
Listen,
them we can at least. Yes, dear. Anybody wanted to say anything? Okay. So CVS, FMU, and NIPT. Now, apart from a routine antenatal care, that means a detailed detailed blood investigation at 11 to 13 weeks. That is booking blood test. Red cell antibodies will be checked here. Hemoglobin will be checked here. NT-NB and double marker. Okay, so double marker will be checked at each visit onward 16 weeks on. Now here we will take an opportunity to start on aspirin to prevent the risk of preeclampsia, and also we will be assessing her a risk of thromboembolism and may consider low molecular weight heparin whenever there will be a risk factor. This needs to be mentioned. Okay, so at each visit we are going to assess. Aspirin will be started, low molecular weight heparin according to the risk factor. She will be started. Okay, after consultation with hematologist. Vaccination and penicillin prophylaxis needs to be continued. Frequent follow-up, serial growth scan, liver function test, kidney function test, frequent hemoglobin check, this RCA, that is red cell antibodies. Seek early advice and help if any red flags. Okay, if I have mentioned red flags. Okay, so for that 24-hour contact detail, and labor plan will be induction of labor at 38 to 40 weeks, one-to-one care, document care, offer patient support group, and patient information leaflet. Okay, we will aim for vaginal birth. C-section is only for maternal obstetric indication. So this is my antenatal care plan for this case. Anybody wanted to add anything? Do you come do means anything coming to your mind, so we can put it out at present, then we can go to the next question. Anybody wanted to put anything?
ma'am, during any pain conditions, pethidine is contraindicated.
Here we are not saying that pethidine is contraindicated. Here we are just managing her, thinking that she will respond to the means she will not be having any crisis. So as of now, if you will not say all those points, still it is okay, dear. Okay, so I had added that also point, but where exactly I will tell you.
Ma'am, one thing I wanted to ask in this, can I ask?
Hmm.
Ma'am,
Yes, definitely.
is distance from the home specifically mentioned in the guideline? I have not read. Maybe I have missed. So I'm just asking.
Yeah. See, whenever this is actually a patient safety points. Whenever there are certain emergency situations, you can decide it. Okay.
Okay,
So even in placenta previa, we need to assess the distance. Okay. Access to healthcare, at least you can say that.
okay, okay, okay.
Okay. Whether there
Oh,
will be easy access to healthcare if there will be an emergency situation and someone with the patient at home.
okay, ma'am.
Okay, this is patient safety point. This is not
Hmm.
an You just read the like guideline somewhere, somehow it has been mentioned. Okay, distance, that they need to be referred to the dedicated this antenatal care units. Okay, and distance from the that health, something has been mentioned. Okay, I will put it down. Okay, I will take a screenshot and put it down. So basically access to health, this emergency services needs to be explained, and 24 hours contact details. Okay, it is very important. This is actually a patient safety point. Hmm? Do not miss out on this. Then coming to the next question. Okay, uh, so I am suspecting an emergency situation. Either it will be what you mentioned regarding second task, acute hip necrosis. Always give differential diagnosis unless we have not diagnosed the situation with the help of investigations. Okay, so it could be a painful crisis, or it could be a acute hip necrosis due to uh, sickle cell disease. Okay, sickle cell disease. So either of these, whatever you have think, admit, resuscitation and stabilization, emergency critical situation with the help of MDT. You had involved proper all the patients, MDT people in this case. Okay, now here I will suggest you to go systematically. Okay, go systematically. What? So we had admitted her, then we can say tell components of MDT. Okay, assessment of patient's diagnosis by offering relevant investigations, and management and diagnosis according to the cause. So admission and urgent assessment by emergency registrar. I had, means I am going systematically. The first person to come in contact will be the emergency registrar, and consult me also, me. Then I will inform my consultant, HDU physician, hematologist here, hematologist, and even the anesthetist. And since I am suspecting acute hip necrosis or ACN of sickle cell disease, I'm involving orthopedician also. Okay, so suspected necrosis of bone, if I'm suspecting that. Neonatologist, if I'm at all planning the delivery, otherwise I'm not going to involve. So these are my people whom I have involved here. Assessment of history and examination, and patients needs to be monitored on MEOS chart, which includes our vital parameters, input output, oxygen saturation. ABC approach you had mentioned regarding the oxygen. Okay, oxygen by mask you had mentioned. Position her propped up because oxygenation is needed. IV cannula to collect baseline blood investigation and fluids. Okay, I start, and whenever once I means I'm having a habit of putting a IV cannula, collecting a baseline blood investigation, and starting her on fluids. So these fluids will help her to ease out on hydration. Hmm? Just wait. Okay, now X-ray knee joint, sorry, X-ray knee hip joint, whatever it is, X-ray of the joint. Okay, whether it is knee pain or whether it is hip pain. So X-ray of the joint, X-ray we need to start. Then step WHO here, that is a buzzword here, or a star word, or you will be getting a star point. You had mentioned regarding the analgesia ladder, but you have not taken that point. Okay, so WHO analgesia ladder. According to that ladder, uh, I will start her on analgesics. Painkiller, no. A big no for painkiller. So say analgesia ladder. So it will be started from simple analgesic like means paracetamol, codeine, and then IV parenteral analgesic like morphine. Okay, keeping everything in mind here. Follow WHO analgesia ladder step ladder pattern needs to be followed. Avoid pethidine. Very nicely, Dr. Rajni has elaborated how frequently effective analgesia within 1 hour. The guideline says that the effective analgesia within 1 hour is very important. Broad spectrum antibiotics, because we are suspecting it can be any kind of infection also, and injection penicillin after allergy. Urine culture sensitivity, antibiotics accordingly, assessment for thromboembolism, and starting of low molecular weight heparin according to the body weight. This will take care of acute painful crisis, which is common in pregnancy. Also consider exchange transfusion if no response to acute chest syndrome or painful crisis. This will be decided by a hematologist. This is not going to be decided by us. So after hematologist opinion, and document her care. Or at each point you are here also we need to say document her care. We had mentioned, yes. So documenting her care is very important. This is a high risk pressure pregnancy. So documenting her care is very important. Always say document her care. Completed question number 2. Any question, any answer? Anybody wanted to say anything in this question? Shall we move on to the next one? Anybody? No answer? Am I audible?
Yes, ma'am, we can move ahead.
Yeah. Now the patient has admitted in labor at 39 weeks of gestation in spontaneous labor. Okay. Admit her in labor room, which she has admitted. Check her labor plan. What is her labor plan? Generally, they do have a labor plan, MDT, in accordance with the hematologist, obstetrician, and neonatologist anesthetist. Inform consultant, neonatologist, anesthetist, and theater people. IV line group say withhold low molecular weight heparin if she is on low molecular weight heparin. Assessment and stabilization on patient. Assess fetal well-being also. So offer her USG, Doppler, NST depending upon the situation. IV line group say okay, here this is double. Okay. Even hemoglobin assessment is very important here. Hmm? Hemoglobin assessment. Keep ICU or HDU or level 2 critical care bed reserved for this patient in case of any crisis situation. Continue monitoring on MEOS chart and partogram, which is very important here. If no obstetric risk factor, you can continue you can offer this patient vaginal mode of delivery. Adequate pain relief. Avoid pethidine. Again, we are saying here, avoid pethidine. And especially epidural can be considered in this case. Okay, in this case. Hydration is very important. So, IV fluid. Hydrate this patient accordingly. Continuous fetal, okay, we had continuous monitoring of the patient. So, here we are say continuing electronic fetal monitoring of the baby. Assess labor progress according to guideline and document the care. Okay. Uh, this is what our antenatal care. Anybody wanted to say anything? One-to-one care, support, all those points you can mention here. Okay. So basically one-to-one care, CFMT, vaginal, aim for vaginal birth, hydration, group and cross match. She is at risk of PPH. So now coming to the next question. Active management of third stage of labor. Baby will to be assessed by neonatologist. Okay. Very nicely she has mentioned. Heel prick test for baby status. Okay. Baby status. Okay. So that needs to be assessed and communicated with the patient. VT assessment and low molecular weight heparin accordingly. You can restart here on. Hydration, very important. Encourage breastfeeding. Contraception, especially DMPA. Okay. It minimizes the risk of sickling crisis. Avoid COC, very nicely you had mentioned. Document her care. Offer patient information leaflet of second sickle cell disease in pregnancy, and patient can be discharged once the criteria will be met to the primary care and communicated with the GP surgery. This can be end of it. Okay. Anybody wanted to say anything? Anybody wanted to add?
No, ma'am.
No, ma'am. Too elaborative and good one. No point in adding our points. Thank you so much for giving me this opportunity. I would like to present once more if next class.